forum. So my talk today is on role of Sbrt in recurrent and metastatic CA prostate. As we know, the role of Sbrt is increasing significantly in prostate cancer management. And let us see in this special two scenarios, that is in the recurrent scenario and in the metastatic CA prostate, what is the role of Sbrt? So there are two situations I have been asked to discuss today. One is recurrent, another is metastatic. So recurrent CA prostate can be post-surgery, that is post-radical prostatectomy, or post-EBRT. And the metastatic setting can be a low-volume metastatic or an oligometastatic setting. We know that it is gaining importance every day, and a high-volume metastatic setting. So I'll mainly discuss today the prostate-directed Sbrt, that is in post-surgery scenario and post-EBRT recurrent scenarios, and for the low-volume metastasis. Because I don't think I have adequate time to discuss Sbrt to metastatic sites, because it's a vast topic and it depends on the different sites also, and there are many articles on this. So I'll confine my lecture to recurrent prostate cancer, that is post-radical prostatectomy recurrent and post-EBRT, and to the low-volume metastatic disease. So mainly I'll discuss prostate-directed Sbrt. So first of all, why Sbrt? Because I probably prostate is the most suitable site for Sbrt, because as we all know from our radiobiology knowledge, that alpha by beta of prostate is very low, that is around 1.5. And this is the organ where Sbrt or a very high dose per fraction should work very efficiently. Another thing is Sbrt, the duration of treatment is short, the shorter treatment time, which and allows us to avoid any delay in the systemic treatment, because in both the scenarios, in recurrent and in metastatic scenarios, the patient will need systemic treatment as well. Though in prostate cancer, many systemic treatment can be given concurrently with radiation, but there are few treatments which cannot be given concurrently too. It's a non-invasive process because in recurrent and in metastatic settings, we try to do as less invasive as possible. So side effects are lesser, and it is, so we can call it is faster, better, and cheaper. Faster because instead of 40, around 30, 37 or 40 treatments, you can finish it in 5 treatments. And it is cheaper in every country. This is the US data. In our country also, even in my hospital also, it is cheaper than any IGRT treatment. And let us see whether it is better or not. There are multiple studies showing excellent controls. I will discuss some of the studies to know whether it is better or not. So the first one is Sbrt post-EBRT. So this is a case report which was published in 2015 by Arkangeli. It's a famous clinician. He published so many data on prostate. So this is one patient's data who was treated initially with 66 gray in 36 fraction, and retreatment was done with 30 gray in 5 fractions in consecutive fractions of 6 gray each. And he concluded that radiation therapy was well tolerated. After a follow-up period of 6 months, the patient remains healthy, and there has been no further evidence of metastasis, spread, or recurrence. The next one is published in 2017. It's 23 patients' data, but Thomas Leroy. So they were treated with Sbrt for intra-prostate cancer recurrence with a median follow-up of 22 months. And they concluded that Sbrt for local prostate cancer recurrence seems feasible and well tolerated with short follow-up time. And as you know, they have recommended that prospective evaluation is needed. So this data is a big data. It's they collected the data from multiple centers, 7 centers, 100 patients' data, published from France in 2019. So Sbrt dose median was 36 days in 6 fractions every other day, and median follow-up of 29.3 months, and the second biochemical recurrence-free survival rate at 3 years was 55%. And no patient developed acute gastrointestinal toxicity of grade 1. That is important that we want to know. The rates of acute genitourinary toxicity of grade 2 and 3 were 8% and 1% respectively. The actuarial 3-year grade 2 genitourinary and gastrointestinal toxicity was 20.8% and 1% respectively. And they concluded that with a short follow-up, this study shows that salvage Sbrt allows for encouraging control and acceptable toxicity. And they have recommended further prospective studies, but it's a big data of 100 patients. So another data, this is from USA. It's a 50 patients data, biopsy-proven recurrent prostate cancer with more than 2 years after prior treatments. And they are retreated with high dose rate like dose, like 34 gray over 5 fractions. In the previous radiation in these patients, they received the full dose of radiation 75.6 gray. The median interval was 8.1 years. So after a 44 months of median follow-up, the 5-year biochemical disease-free survival was 60%, with the corresponding 5-year actuarial local distant and salvage androgen deprivation therapy-free rates were quite good, 94%, 89%, and 69%. And they concluded Sbrt salvage of local prostate recurrence in previously treated patient appears clinically feasible in this challenging group. It demonstrates favorable PSA and DFS response, typically deferring the need for salvage androgen deprivation therapy or other treatment by over 5 years with low GU and GI toxicity. This data is from Italy of 64 patients and the 2-year local control biochemical and clinical relapse-free survival rate was 70, 40, and 53%. With BED more than 130 gray, 1-year biochemical and clinical progression-free survival rate were 85 and 90% respectively. So median total dose was 30 gray in 5 fraction. And they also concluded that salvage Sbrt, that is retreatment for isolated local prostate cancer recurrence, is safe, feasible, and non-invasive salvage treatment. Salvage Sbrt irradiation for the locally recurrent prostate cancer offers a satisfactory tumor control and excellent toxicity profile if BED more than equal to 130 gray is administered. So another data, this data, this is a 19 patients, it's a meta-analysis actually, systematic review and meta-analysis of 13 cohorts, 19 studies, 428 patients, and the weighted mean follow-up was 26.1 months, median RT-QD2 was 77.1 gray, and in this cohort, 92% of patients received Sbrt. So it's excellent local control, 83.2%, and biochemical relapse-free survival was 59.3%, and late toxicity of grade 3 was only 3.4% for GU and 2% for GI. And they concluded salvage DRT using Ebrt, particularly with Sbrt, is an emerging technique to treat isolated local failure of prostate cancer with short-term follow-up, local control, biochemical relapse-free survival, and reported toxicities appear reasonable, although further follow-up is required before definitive statement on late toxicities can be made. It's quite a big data of 428 patients. So let us see what an Istro-ACOP-Delphi consensus is. So the consensus, the green one is the issues where consensus was achieved. That is for this, no maximum age, recommended ECOG is 0 to 1, previous ADT represents no contraindication, and IPSH should be known. Maximum Q max at salvage, there is no inferior value. CTV to GTV defined on multiparametric MRI plus adaptive margin. For metastatic disease should be evaluated. Imaging for metastatic disease evaluation is choline PET. ADT should not be delivered concomitantly with re-irradiation. Phoenix definition of biochemical relapse is valid for retreatment patients. Primary treatment dose should be always considered when deciding salvage Sbrt dose. This is the consensus statement. So now the second part is Sbrt post radical prostatectomy. This is a bit gray area. We have very less data on this. So these are some articles published by Oliver, Genore, Deci, and Zerini. So you can see the number of patients. The number of patients are less, 12, 10, 8, and 10 patients data. So all this data has been discussed in this systematic review, which has been published on 29 January 2022, fresh from the oven. And Dr. Bedang Murthy from India is also part of this systematic review. 11 publications included in this systematic review. So there are two categories. One is adjuvant prostate-based Sbrt without prior radiotherapy, and another category is prostate-based Sbrt who has received prior radiotherapy post-radical prostatectomy. So there are three studies of this Sbrt without prior radiotherapy, and there are few other studies for prostate-based Sbrt with prior radiotherapy. So these are radical prostatectomy patients who had received radiotherapy also and who has been salvaged with Sbrt. And as you can see, the doses are around this 30 gray 6 fraction or 5 into 7 gray 6 into 6 gray. Almost they are similar in these multiple studies. So these are the studies. Because the slide was so busy, I thought you should know the names. So this is the toxicity profile they have plotted. The size of the sphere represents the number of the patients. So as you can see, the GI toxicity, these are the patients without prior radiotherapy, only RP followed by salvage Sbrt. So these are the patients. As you can see, the biggest study, that is Francolini, that is the 90 patients. So acute GI toxicities are less, and so on late GI toxicities are also not very much, and GU toxicities are less. Though the smaller studies, they have shown a little higher GI toxicities, like this study. This is only 26 patient study, and their late GU toxicity has been quite significant, around 40%. But most of the patients are less than 8.56%, which is the median. Similarly, these are the patients who had received prior radiotherapy. So as you can see, and as we compared with the previous graph, in this graph, the toxicities are even lesser. So in GI toxicity, both early and late toxicities are less. In GU toxicity also, the early and late toxicities are less. There are one or two outliers, but as you can see, the number of patients are very less in these studies. So the studies which has more number of patients, their toxicities are not very significant. So this is the complete response rate. So in different studies, around 40 to 42% in most of the studies, and pattern of failure also. So the infill failure in this study, Francolini, was 2.2%, and so everything was not reported in all the studies. And Jerek Fossa and Fossa studies, it was 36%. Olivier studies, it was 16.7%. So biochemical failure was 13.3%. In Francolini studies, 11.1%, in another studies, and around 14%. So, but the conclusion we need to know, at this point, they have said ultra high percentage RT using Sbrt to the prostate bed remains experimental, and its use should be restricted to clinical trials given the biological rationale for extreme hyperfractionation in patients with prostate cancer and the acceptable toxicity rates that have been reported. But further exploration of this field is warranted. So maybe now it can be used in the clinical trial scenario only. And the third and the last one is the Sbrt in metastatic prostate cancer. As we all know, because I think my time is less, so I'll finish early. So as we all know, there is an entity called oligometastatic disease. Nowadays, it is being discussed in all the forums. So this is a stage where the metastatic capacity is limited. In the localized disease, there is no metastasis, and widespread systemic disease, there is full metastatic capacity. And there is a stage in between these two where the metastatic capacity is limited. So the idea is, if we can if we can treat the oligometastatic disease, and we can prevent the spread to widespread metasystemic disease. So the rationale is it prevents the second wave of metastasis, and the proliferation of metastatic cells are dependent on some compounds which are secreted by the primary tumor. So if you kill the primary tumor, these will not be secreted. And the most important theory, that is the seeding and the soil theory, which is important and widely accepted. So lethal clone actually arises from a small, relatively low-grade cancer focus in the primary tumor and not from the bulk. So higher-grade primary cancer or lymph node metastatic resected during RP. The clone most closely related to the metastasis was found in an intraductal carcinoma of prostate cancer. So circulating tumor cells can also colonize their tumors of origin in a process they call tumor self-seeding. So primary tumor can act as a self-seeding site for circulating tumor cells primed and deposited from established metastasis site. So if we treat with local therapy to the primary tumor or a metastatic site, it may alter the tumor biology and result in depressed growth and may limit the establishment of new metastatic sites. So this is the rationale of prostate-directed treatment. And this is a data, the big data from National Cancer Database, 6,382 men's data, which was published in JCO. And they have shown that improve overall survival if we treat the metastatic disease, if we target the local, if we offer local treatment. And they concluded that in this large contributory analysis, men with metastatic prostate cancer receiving prostate RT and ADT lived substantially longer than men treated with ADT alone. But they have said, yes, we need prospective trials. So median 5-year OS was 55%, 37 months, which was statistically significant. Then we have the HORA trial. So in HORA trial, 432 patients data. So some of them received ADT, some of them received ADT and local treatment, and 67% of patients had more than 5 osseous metastases, which is above the low volume definition. So there was no difference in overall survival, and it was 45 versus 43 months, and there was no clear benefit in any group was found. So possible benefit in those with less than 5 meds. Then came the Stampede trial, the multi-arm, multi-stage, multi-center trial. The Stampede trial arm H has 2,061 patients. Half of them received ADT with or without docetaxel. Rest of them received ADT with local RT. 2 dosing schedule, 55 day in 20 fractions and 36 in 6 weekly fractionation. But there was no OS difference in the entire group, 46 versus 48. There is improved failure-free survival. 3-year failure-free survival was 23 versus 32. But when we analyze the low burden disease, so what is high metastatic burden? More than equal to 4 or more bone metastasis with 1 or more outside the vertebral body's pelvis, or visceral metastasis, or both. This definition has been taken from the Charted trial. And in low burden patients, which was significant number, 819 patients, RT improves failure-free survival and 3-year overall survival, 81% versus 73%. So there is a meta-analysis called StopCam meta-analysis. They have taken HORA data and the Stampede data, 2,126 men, and there was 969 deaths. Improved 3-year biochemical progression and failure-free survival approximately 10%, and in low burden, less than 5 bone mets, absolute improvement of 7% in 3-year overall survival. So they have shown that actually there is a survival benefit, absolute benefit of 7% in 3-year in overall survival if we offer local RT in low burden metastatic prostate cancer. So now in ESMO guideline also in hormone naive metastatic prostate cancer in low burden disease, they have included ADT plus prostate RT. So, so why I was discussing Sbrt. So what is the proof of Sbrt will help in this situation? In the Stampede trial also, as we see, the weekly regimen received, that is 36 gray in 6 fractions, which is essentially Sbrt, received by almost half of the patient, around 47 to 48% of patient in both the arms. So this is actually an Sbrt protocol, and half of the patient in this trial received Sbrt. So if the Ebrt helps, so in this scenario, Sbrt should also help. From the same data, we can conclude that. We have another data which was presented by Dr. P.S. Sridhar from India, because this data I could find from India, so I thought I'll be presenting this also. They have treated 35 metastatic prostate cancer patients who were treated with Sbrt on ADT between June 2009 and 2018, and they analyzed. All patients tolerated the treatment well with acceptable toxicities. The mean overall survival was estimated to be 117.53 months, which is incredible, and with a standard rate of 15.834, and 5-year survival rate for this group was 87.5%. And they concluded that in patients with metastatic prostate cancer treated with ADT Addition of Sbrt is well tolerated and trends towards survival benefit. In the study, benefit was more for oligometastasis. However, this should be validated in a randomized control trial. So we have now the Stampede data. I think the Stampede data is a huge data. Lots of patients were treated with this regimen, that is 36 in 6 fraction weekly Sbrt. And as Sbrt is evolving, as we know, in different, in localized prostate also Sbrt is coming in a big way, and people are trying daily fractionation instead of weekly fractionations Sbrt. And from India also, from TMC Kolkata, Dr. Indranil Malik has presented his paper in localized prostate cancer. And I believe that soon in metastatic prostate cancer also this regimen will become more and more popular and more effective. So thank you for inviting me. I acknowledge Dr. Moses Arun Singh for providing me some of the slides and helping me to preparation of this talk, and Dr. Kanu Charan Patru. Thank you all.
Thank you, sir.